Good morning, everyone. Today's presentation is about radiation biology. Let's have a brief discussion about it. Moving on to contents, we'll have a look on introduction, history, radiation chemistry, classification of biological effects of radiation, radiosensitivity, modifying factors, biological effect on cells, on organs, on whole body, on oral tissues, and conclusion. What is radiation biology? It is the study of the effects of ionizing radiation on living systems. So why we should need to know about radiation biology? Because it has become an integral part of diagnosis and treatment in dentistry and cancer therapy. At the same time, the radiation affects the human body by different ways and produces various health effects. So understanding the mechanism of action, clinical manifestation and preventive measure is important. Looking back to history, biological effect of radiation started shortly after the discovery of radiation in 1895. Becquerel was the first to experiment by leaving a radium container on his pocket intentionally. He developed erythema after 2 weeks, which leads to ulceration, and it took several weeks to heal. Pierre Curie repeated the same experiment in 1901 by applying radiferous barium chloride on his skin for 10 hours, inducing a radiation burn on his forearm. In 1911, the first exposure of leukemia in human from occupational exposure was reported. Speer in 1953 discovered a variability in radiosensitivity in cells of various tissues, sparing the effect of fractionation and reduced dose rate and the latency period between the radiation and the manifestation of effects. How do X-rays cause damage? When radiation exposure occurs, photons and secondary electrons are released, which causes ionization of biologic macromolecules by two ways, either through direct effect or indirect effect, which result in alteration of cells and organisms both structurally and functionally by direct DNA damage or indirectly causing DNA damage. Direct effect. When energy of photon or secondary electron ionizes biologic macromolecule, the effect is termed as direct effect. They form unstable free radicals and an unpaired electron. These free radicals are extremely reactive and have short lives. So they reform into stable configurations by two ways, by dissociation or by cross-linking. Dissociation means breaking apart and cross-linking is joining of two molecules. Therefore, the biologic molecules differ both structurally and functionally. About one-third of biological effects of X-ray exposure result from the direct effects. On to indirect effect. 70% of water is in biologic molecules, which is involved in the interaction between X-ray photons and biologic molecule. A series of changes occur in water after exposure to ionizing radiation, which is called radiolysis of water. Water is then converted to hydrogen and hydroxyl free radical. When hydrogen and hydroxyl free radical interact with the organic molecules, they form organic free radical. So two-thirds of the biological effect of X-ray exposure results from indirect effect. So the total time for both direct and indirect effect to occur is about 10 to the power minus 5 seconds. So both direct and indirect effect result in DNA damage. DNA damage is the primary cause of radiation-induced cell death, heritable and cancer formation. So it produces different types of alteration in DNA like single strand breakage, double strand breakage, cross-linking of DNA strands within the helix to other DNA strands or to proteins, change or loss of base, disruption of the hydrogen bond between the base. Of these, single strand breakage and double strand breakage are the most common type of damage occurs, in that the single strand breakage is of easily repaired by using an intact second strand as a template. Biologic effects of radiation can be classified in three ways: deterministic and stochastic effects, somatic and genetic effects, short-term and long-term effects. Deterministic effect. Radiation injury to organism occurring due to killing of large number of cells is deterministic effect. Here it can occur through either lethal DNA damage, cell death, or decrease in the tissue and organ function. Deterministic effects seen when the radiation exposure to an organ or tissue exceed a particular threshold level. At a dose below threshold level, the effect does not occur. Therefore, these deterministic effects are dose dependent. So, severity of response is proportional to the dose. Greater the dose, greater the cell killing effect. Examples include xerostomia, mucositis resulting from radiation therapy, osteoradionecrosis, cataract formation, and decreased fetal development. Moving on to stochastic effect. These are dose independent effect. These stochastic effects are caused by sublethal damage to the genome of the individual cell, resulting in cancer formation or heritable mutation. Examples include leukemia, thyroid cancer, salivary gland tumors, and other heritable disorders. They have no minimum threshold for causation. Any dose of radiation has the potential to induce stochastic effect. So, therefore, these are dose independent effect. Let's have a look on biologic effect of radiation on cells. First is the nucleus. The sensitive site in the nucleus is the DNA within the chromosomes. They are more radiosensitive. Moving on to chromosomes, chromosome aberration is observed in irradiated cells at the time of mitosis when the DNA condenses to form chromosomes. Type of damage depend upon the cell cycle at the time of radiation. So basically the cell cycle consists of 4 phases: G1 phase, S phase, G2 phase, and mitosis phase. G1 phase is the growth phase. S phase is the DNA synthesis phase. G2 is the growth and preparation for mitosis, and this mitosis phase where the cell division occurs. If radiation exposure occur after DNA synthesis, that is in late S phase or G2 phase, only one arm of chromosome is affected. That is chromatid aberration occurs. But if radiation induced break occur after replication, that is in G1 or early S phase, then you can see break in both the strands. And this chromosome aberrations can be detected in the peripheral blood lymphocyte of patients exposed to medical diagnostic procedures. Therefore, the frequency of aberration is proportional to the radiation dose received. Moving on to cytoplasm, irradiation of cytoplasm causes increased permeability of plasma membrane to sodium and potassium ions, causing swelling and disorganization of mitochondria and focal cytoplasmic necrosis. And then moving on to proteins. Irradiation of protein leads to changes in their secondary and tertiary structure by disruption of side chain or breakage of hydrogen or disulfide bond, causing denaturation of the proteins. Moving on to cell kinetics. Here, the radiation of rapidly dividing cell systems causes reduction in the size of the irradiated tissue as a result of mitotic delay and reproductive cell death. The three mechanisms of reproductive death are DNA damage, bystander effect, and apoptosis. So what is this reproductive cell death? That is, here you can see a dominant mode of cell killing where the cell die when they attempt to divide. A double strand breakage in DNA cause a frequent cause of cell death. Apoptosis, it is nothing but programmed cell death, which is more common in hematopoietic and lymphoid tissues, and it is observed after low dose of radiation exposure. It occurs within hours after radiation exposure, seen in lymphomas, serous cells of salivary gland. What is bystander effect? Here, the cells that are damaged by radiation release into the immediate environment molecule, causing killing of nearby cells through chromosome aberrations, cell killing, and gene mutations. Moving on to somatic and genetic effect. Somatic cells are the cells in the body other than reproductive cell, whereas genetic cells are germ cells found in the reproductive organ. Radiation can damage somatic cell, but the damage is not transmitted to future generation, whereas in genetic effect it is passed on to the future generations. And examples of somatic effect include radiation-induced cancer like thyroid cancer, esophageal, brain, leukemia, and cataract. Genetic effect are the changes seen in the offsprings of irradiated individuals. Short-term and long-term effect. The radiosensitivity of a tissue or organ is measured by its response to radiation. The short-term effect of radiation is seen in first days or weeks after exposure, and they are determined primarily by the sensitivity of its parenchymal cells. When the continuously proliferating tissues, for example the bone marrow or oral mucous membrane, when they are irradiated with a moderate dose, the cells are lost by apoptosis, bystander effect, or reproductive cell death. But when the cells that rarely divide, like muscles or neuron, they demonstrate no radiation-induced hypoplasia over a short-term effect. So those cells are low radiosensitive, whereas the proliferating cells are highly radiosensitive. So the extent of cell loss depend upon proliferative rate of the cell damage to the stem cells. Next is the long-term effect. These are the effect of radiation on tissues and organs seen months and years after exposure. They depend primarily on the extent of damage to the fine vasculature or reproductive death of replicating cells. For example, damage to a capillary lead to impairment of the transport of oxygen, nutrients, and waste product, which result in death of all cell type which is dependent on the vascular supply. So therefore both dividing and non-dividing cells, that is radiosensitive and radio-resistant cells, are replaced by progressive fibrosis. So this progressive fibroatrophy of irradiated tissue occurs. So what is radiosensitivity? It is defined as the ability of radiation to biologically change cell comprising a tumor or other tissues. So let's have a look on relative radiosensitivity of various organs. It can be classified into high radiosensitivity, intermediate radiosensitivity, and low radiosensitivity. So high radiosensitivity organs include lymphoid organs, bone marrow, testis, intestine, and mucous membrane. These organs, they divide regularly and they undergo no or little differentiation between mitosis. And intermediate radiosensitive organs such as fine vasculature, growing cartilage, growing bone, salivary glands, lungs, kidney, and liver, they divide occasionally in response to demand for more cells. The third one is the low radiosensitivity organ like optic lens, mature erythrocyte, muscle cells, and neurons. These are highly differentiated and when mature, they are incapable of divisions. Coming to Casaret's division of radiosensitivity, here it is classified into 5. The first is vegetative intermitotic cells, differentiated intermitotic cells, multipotential connective tissue cells, reverting postmitotic cells, and fixed postmitotic cells. Vegetative intermitotic cells are most radiosensitive and they include cells of spermatogenic or erythroblastic series and basal cells of oral mucous membrane. Next is differentiating intermitotic cell, which are less radiosensitive and they include inner enamel epithelium of developing teeth, cells of hematopoietic cells in intermediate stage, spermatocytes and oocytes. Next is the multipotential connective tissue cell, which are intermediate radiosensitive and they include vascular endothelial cells, fibroblasts and mesenchymal cells. The fourth one is reverting postmitotic cell, which are radio resistant and they include acinar and ductal cells of salivary gland and pancreas, parenchymal cells of the liver, kidney and thyroid. Fifth one is fixed postmitotic cell, which are most radio resistant and they include neurons, striated muscle cells and squamous epithelial cells. Modifying factors. There are certain factors like dose rate, oxygen, linear energy transfer, nature of irradiated tissues, fractionation, and age of the patient, which can be modified to reduce the effect of radiation on the tissues and cells. So first is the dose. The amount of damage is proportional to the dose. The severity of deterministic damage seen in the irradiated tissues or organ depend on the amount of radiation received. Next is the dose rate. Increase in dose rate causes increased damage. Dose rate indicates the rate of exposure. Exposure of biologic system to a given dose at a high dose rate causes more damage than exposure to the same total dose given at a lower dose rate. Next is the oxygen. Radio resistance of many biologic systems increases when the exposure is made with reduced oxygen. Greater cell damage occurs in presence of oxygen as they form increased amount of free radicals. Next is the linear energy transfer. The dose required to produce a certain biological effect is reduced as the linear energy transfer of radiation is increased. Higher linear energy transfer radiations such as alpha particles causes more damage as they deposit energy densely, causing more localized and potentially damaging effects, while the low linear energy transfer radiations like X-rays and gamma rays deposit energy more sparsely so that there will be less damage. Nature of tissue irradiated. Different tissues have different radiosensitivities, with some being more susceptible to radiation damage than others, as we saw earlier. Next is the fractionation. It is nothing but division of dose with sufficient gaps which help in tissue recovery. The radiation treatment is administered as many daily small doses, which we call as fractions. And this fractionation allows increased cellular repair of surrounding normal tissues that are unavoidably exposed. At the same time, it increases the mean oxygen tension in an irradiated tumor cells, so causing those cells more radiosensitive. So results from killing rapidly dividing tumor cell and shrinking the tumor mass after first few fractions, thereby reducing the distance that oxygen must diffuse through fine vessels to reach the tumor and then to reach the remaining viable tumor cell. Next is age. The younger one have higher chances of recovery comparative to the old. So here are the susceptibility of various organs to radiation-induced cancer. It can be classified as highly susceptible, intermediate and low susceptible. Highly susceptible organs are colon, stomach, lung, bone marrow and female breast. Intermediate susceptibility includes organs like bladder, liver, thyroid. And low susceptible organs include bone surface, brain, salivary glands and skin. Moving on to biologic effect of radiation on whole body, which is also called as acute radiation syndrome. Acute radiation syndrome is collection of signs and symptoms experienced by individual after a acute whole body exposure to radiation. There are few phases in acute radiation syndrome. The first is the prodromal period. This occurs within first minutes to hours after the exposure to whole body radiation of about 1 to 2 gyri. So the person may experience anorexia, nausea, vomiting, diarrhea, weakness and fatigue within hours of exposure. Next is the latent period. This is the period between radiation exposure and onset of symptoms. So the person shows no signs or symptoms of radiation sickness. The extent of latent period is also dose related. It can last from hours or days after supralethal exposure, that is approximately more than 5 gyri, to few weeks after exposure of about 2 gyri. Next is the hematopoietic syndrome. This hematopoietic syndrome occurs when the exposure of about 2 to 7 gyri cause injury to mitotically active hematopoietic stem cells in the bone marrow and spleen. So there will be a rapid decrease in number of circulating granulocyte, platelets and finally erythrocyte. So when decrease in number of granulocyte leads to infection, decrease in number of platelet causes hemorrhage and finally decrease in the erythrocyte causes anemia and death occur within 10 to 30 days. In this, the hematopoietic stem cells are radiosensitive whereas the mature blood cells are radioresistant. Next is gastrointestinal syndrome. It is caused by whole body exposure of 7 to 15 gyri. And here the person experience loss of epithelial layer of intestinal mucosa, loss of intestinal absorption, and therefore they result in hemorrhage, diarrhea, dehydration, and weight loss. This marked lowering of body's defense against bacterial infection and decrease in effectiveness of clotting mechanism, the combined effect of damage to hematopoietic and gastrointestinal stem cells cause death within 2 weeks from fluid and electrolyte loss and possibly nutrition impairment. Next is cardiovascular and central nervous system syndrome. Here it occurs when the exposure is greater than 50 gyri and the death occurs in 1 to 2 days. And here they experience fall in BP, circulatory collapse, stupor, disorientation and convulsions. Acute radiation syndrome is managed initially by the symptoms which is being experienced by the patient, and next is through antibiotic which are indicated when the granulocyte count is decreased. Then fluid and electrolyte balance replacement when it is necessary. Next is the whole blood transfusion to treat anemia, and platelet administration to arrest bleeding. Moving on to biologic effect of radiation on oral tissues. Basically, 5 tissues are involved, that is oral mucous membrane, salivary glands, taste buds, teeth and bone. So first let's see one by one. Oral mucous membrane. Here there will be inflammation of oral mucosa due to radiotherapy. By the end of second week, area of redness and inflammation, which is called as mucositis, develop. As the therapy continue, the irradiation of the mucous membrane begin to separate from underlying connective tissue with formation of white to yellow pseudomembrane, that is the desquamated epithelial layer. At the end of the therapy, healing occurs and the mucosa becomes atrophic, thin and avascular. And the oral hygiene should be maintained properly. If not, candidal infection is more common to occur. And this irradiated mucosa begins to heal rapidly, and healing usually complete by about 2 months. Moving on to treatment, topical anesthetics can be given like xylocaine, diclonine, diphenhydramine hydrochloride. Analgesic agents like benzathine hydrochloride can be given as mouthwashes. Antifungal agents like clotrimazole cream 1% and ketoconazole 200 to 400 milligram tablets for 2 weeks in case of any candidal infections. Next is the taste buds. Taste buds are sensitive to radiation. Loss of taste occurs during the second or third week of radiotherapy. Bitter and acid flavors are affected when posterior two-thirds of tongue is irradiated, whereas salt and sweet flavors are affected when anterior third of tongue is irradiated. The recovery takes 60 to 120 days and the taste loss is reversible. And it can be treated by giving zinc sulfate 220 milligram. When coming to salivary gland, the major salivary glands are unavoidably exposed to 20 to 30 gyre of radiation during radiotherapy for cancer in oral cavity or oropharynx. Whereas the parenchymal component of salivary gland is more radiosensitive and which cause marked and progressive loss of saliva within first few weeks after initiation of radiotherapy, and it reaches to 0 at 60 gyri. The mouth becomes dry, tender and swallowing is difficult and painful. And the recovery usually occur in 6 to 12 months. The treatment is usually symptomatic. If there is more symptom, more hydration, mouth rinses and gels are advised, and topical salivary stimulation like sugar-free gums or mints can be given, and systemic salivary stimulations like pilocarpine 5 mg, bethanacol, cevimeline or anethylletrethione can be given. If some portion of major salivary glands are spared, dryness of mouth usually subsides in 6 to 12 months because of compensatory hypertrophy of residual salivary gland tissues. Next is teeth. Irradiation of teeth with a therapeutic doses during development severely retards their growth. Children receiving radiotherapy to the jaw may show defect in permanent dentition such as retarded root development, dwarf teeth or failure to form one or more teeth. If exposure precedes calcification, it may destroy the tooth bud. If radiation occurs after calcification, it may inhibit cellular differentiation causing malformed and arrested general growth. In children receiving radiotherapy, they may have retarded tooth development, dwarfed teeth, impermanent dentition. At the same time, the eruptive mechanism of teeth is radiation resistant. The irradiated teeth with altered root formation still erupt. Caries is a rampant form of dental decay that may occur in individuals who receive a course of radiotherapy, which also include the exposure of salivary glands. So they have increase in Streptococcus mutans, Lactobacillus and Candida. Caries result from decreased pH, reduced buffering capacity, reduced salivary flow, increased viscosity and altered flora. Radiation has a direct effect on teeth, more prone to breakdown with flaking of enamel, particularly in areas of occlusal loading or stress. The destruction is seen with a dose greater than 30 gyri and is pronounced when the teeth receive more than 60 gyri. Clinically, there are three types of radiation caries. The most common is widespread superficial lesions attacking buccal, occlusal, incisal, and the palatal surfaces. So, here you can see the second type, that is primarily the cementum and dentin in the cervical region are affected, and you can see it progressively affects around the teeth circumferentially. The third type is dark pigmentation of entire crown. Incisal edges may be markedly worn. Moving on to treatment, the restorative dental procedure and good oral hygiene can be maintained to prevent radiation caries. Application of viscous topical 1% neutral sodium fluoride gel in a custom made tray for 5 minutes daily can prevent from radiation caries. Next is bone. Treatment of cancer in oral region often includes irradiation of mandible or maxilla. The primary damage to mature bone results from radiation-induced damage to the vessel of periosteum and cortical bone, and radiation also acts by destroying the osteoblast and to a lesser extent osteoclast. It typically causes breakdown of oral mucosa with exposure of the underlying bone, and the risk is more at especially more than 60 gyri. Mark explained a 3H principle. Type 1 is the osteoradionecrosis develops shortly after radiation. Type 2, it develops year after radiation and follows a trauma-like extraction. And type 3 occurs spontaneously without previous traumatic event like infections, which occur 6 months to 3 years after radiation. Pain, swelling, trismus, halitosis, food impaction in the area, and exposed bone and the pathological fracture are the signs and symptoms. In radiographs, we can see the sequestra, that is dead bone or involucre, can occur. And a non-sclerotic radiolucent modeling can be seen. Moving on to treatment, tooth with poor prognosis should be removed before radiation. Oral hygiene regimen should be started. Antibiotics like tetracycline and antiseptics like chlorhexidine should be given to maintain oral hygiene, and local wound care, hyperbaric oxygen therapy 100% under high pressure 2 to 2.5 ATA for 90 minutes should be given, and sequestration of the dead bone should be done along with bone resection. The effect of radiation on human embryo and fetus have been studied in animals, women exposed to diagnostic or therapeutic radiation during pregnancy. Exposure of 1 to 3 gyri during first few days after conception cause undetectable death of the embryo because embryo failed to implant in the uterine wall. The period of organogenesis when major organ system form is 3 to 8 weeks after conceptions. So the most common abnormalities like microcephaly are often associated with mental retardation when the embryo is affected during those period of conception. Stochastic effect results from sublethal changes in the DNA of individual cell. The most important consequence of such damage is radiation-induced cancer. So, the radiation causes cancer by modifying DNA, as we saw earlier, like by base substitution, insertion and deletion of bases, rearrangement caused by breakage and abnormal rejoining of DNA strand, changes in the copy number of DNA segment, and mutation involving growth regulating genes. In principle, even one radiation photon may initiate cancer formation. Next is leukemia. The incidence of leukemia increases after exposure of the bone marrow to the radiation. Atom bomb survivor and patient irradiated for ankylosing spondylitis show a wave of leukemia beginning soon after the exposure, which peaks in 7 years. Next is the thyroid cancer. The incidence of thyroid carcinoma increases in human after exposure. Only about 10% or less individuals with such cancer die of their diseases. Next is the salivary gland cancer. The incidence of salivary gland tumor is increased in patient treated with irradiation of disease of head and neck in Japanese atomic bomb survivor and in person exposed to diagnostic X-ray radiation. Next is the brain and the nervous system cancer. When patient exposed to diagnostic X-ray examination in utero and to therapeutic doses in childhood or as an adult, average mid-brain dose of about 1 gyri. It shows excess number of malignant and benign brain tumors. So let me conclude that all ionizing radiations are harmful and produce biologic changes in living tissues. Although amount of radiation used in dental radiography is small and biological changes does occur. So the dental radiographer and the dentist must have a working knowledge of radiation biology, the study of effect of ionizing radiation on living tissues, to understand the harmful effect of radiation. There are many recent advancements which have developed to reduce the biological effect of radiation as patients are in need for cancer treatment during radiotherapy, like IMRT, that is intensity modulated radiotherapy, and ICRP guidelines have been changed to make sure that there is reduced biological effects to the tissues on the radiation. So here are some references. White and Farrow and Frenny Karjutka textbook of dental maxillofacial radiology.